current management issues with fetal growth restriction, as you know, is a very complex entity. So I will summarize very briefly the three critical steps so we can discuss a little bit in the management of small fetuses. We've been proposing a stepwise approach for several years now. The first one is to identify the small fetus. Is it small or not? The second one is, once you know it's small, it's a critical step, and it's more and more well accepted that you have to classify it. Is it what we're using today, this very confusing terminology? Is it SGA, small for gestational age, or fetal growth restriction? And in reality, what you want to say, is it a high risk or a low risk small fetus? And the third one, how we should follow up this case and when we should deliver according to current evidence. So these are the three critical steps that I will try to go around during the whole presentation and discussion. And I will really focus on number 2 and number 3. Number 1 is a big matter of discussion. As you know, we have 25, well, not that many, but a lot of different growth curves. Should you be using your standard curve? Should you be using intergrowth, grow, the WHO? That's a big discussion. I'm not going to go into that. I think we all agree that you have good ways of finding small fetus. Some people discuss a lot about that, but I will not discuss anything about that. So just measure it, whatever curve you use, and it's small. Let's assume that the first step is there. So the second one is, I know this fetus is small, and I thought, I'm not doing that always, but today I thought, well, maybe I will show you. This is a case. I will try to picture 2 typical cases. That's one of the typical cases. That's could be 36, could be 37 weeks. It's the 8th centile, so it's a small fetus. The Doppler shows that there is a cerebroplacental ratio that is normal. The umbilical artery is also normal, as it should be. And we have an anatomy scan, and we see that it has head, it has arms. So normally it looks like a normal fetus. There's nothing missing, apparently. We have decently looked at the anatomy. And so that's a typical question in most places. So even if I give this topic many times in the world in different places, and sometimes they show me clinical cases, and that's one of these typical cases I just copied from one of my last trips. And so should we deliver? Should we follow her in 1 week? Should we follow in 2 weeks? Or do we need more information? I mean, in many places they would take a decision, or should you deliver? Because you need what? You need more information. Yeah, I mean, in reality, if you would an audit, in many, many units in the world, 10 years ago, they would be delivering this baby because it's small and we are at term. But in reality, we know we need more information. Could be a uterine artery, could be karyotype infections throughout, maybe that could be the cause. Or maybe we should be looking at the growth. I think the question here is, let's start let's go to the direct point. We know that small fetuses, and that's one of the main points. The first point is to know it's small or not. And the second point is, okay, I know it's small. Some fetuses that are small are going to progress until term with normal perinatal outcomes as a group, while some other cases are going to have worse outcomes. So if we take them together, just by the fact of being small, it's going to have higher chances of stillbirth. And that has been shown by many different lines of evidence. But I know that by looking at several parameters, I could classify this as a high risk or as a, let's say, small but lower risk case. And then I can put the label I want. But let's say high risk, low risk. So with the information here, can I make this decision? And you said, no, we need more information. Which is the information we need here? Do we need everything? Or do you really need to have a karyotype in a late case of growth restriction if everything is normal? Probably not. Not infections. And there are studies on that. I mean, there are several. Excuse me, because I will not be showing a lot of papers. We have just 40 minutes, so you have to take my word. But there are studies that have assessed, and it's not really worthwhile looking at that if the anatomy is normal. Uterine artery, is it contributing something? But uterine artery, not in the first trimester, not in the second trimester. I'm saying now. Is it contributing something? What do you think? Yeah. Okay. See, I think it's contributing. I'll try to show you why. And then that's another good question: is fetal growth curve? In the case that you don't have it in many cases. Okay, but just imagine that you have been looking at this fetus every 2 weeks, and then you have a curve for growth, and this curve can be perfect or can be reduced. Is that telling you something? There are several recent papers. So let me show. So should we integrate that? Yes or no? So that's the main point of the discussion. So let's try to discuss a little bit the evidence. That's the first part, as I said. You have found a baby that is small by biometries. You have excluded extrinsic cause. In reality, when we are at term, that is an anatomy scan, okay? And you know it's isolated, and you want to know whether it's in this group of poorer perinatal outcome, higher risk, or lower perinatal outcome. We are putting forward a proposal now to change these names, and I hope that in a few years we will change them. But today, we are still using these definitions, which are very confusing. When you are sending a paper to America, they get very nervous when you use SGA because they think this is a pediatric definition. And when you say fetal growth restriction, you say, well, it was small from the beginning. So, but by convention, it's arbitrary convention, we call them like that. When we think it's high risk, we call it fetal growth restriction, and when we think it's low risk, we call it small for gestational age, which is, I said, is confusing because both are fetal growth restriction, and sometimes, and both are small for gestational age. It's only that one of these groups is associated with a higher risk and the other with low. So the main issue is that you follow a different management. You don't care about the etiology because you are an obstetrician. You're a simple-minded person, particularly if a pediatrician is thinking what you are. So you just have to make a decision, and you have to decide whether I deliver or I don't deliver this baby. I am 37 weeks, 0.4. And what is the best way of discriminating this? For many years, we used uterine artery abnormal Doppler, and one of the main messages is that stop using only, not stop using the umbilical artery Doppler. Of course, you have to continue using it, but not as an stand-alone criterion. Is don't use umbilical artery only. You have to combine umbilical artery. Why? Because in the majority of cases, when the small fetus is detected later in pregnancy, the umbilical artery is going to be normal. This is a cohort of 700 fetuses diagnosed in our units, and you have other studies that are similar. And this is the frequency, the number of cases. You see it's 120 cases detected at 33 weeks. This only reflects when you do the ultrasound, of course, but more or less what it illustrates is that there is a big proportion of small fetuses that are detected later in gestation, and the dark lines are those that had an abnormal umbilical artery, and the lighter part of the bar reflects the proportion which had a normal umbilical artery. So this is abnormal umbilical artery, the darker. So, and as you can see here, when you are diagnosing fetal growth restriction later in gestation, the vast majority of cases are going to have normal umbilical artery. This changes completely when you combine umbilical artery with a second parameter, which is the middle cerebral artery. You combine them, you measure both, you take the CPR, and the CPR is a parameter that looks at the same problem from two different perspectives. So I look at the umbilical artery, I look at the placental resistance, I look at the brain, at the middle cerebral artery, and then I combine them. And this is an example of a real case. If you have a real case with an umbilical artery that's in centile 80, you would classify it as normal. You measure the middle cerebral artery at centile 20, you would classify it as normal, but both are deviated from normality. When you combine them, then the CPR is less than the 5 centiles. So this case would have been missed by using only umbilical artery, but when you combine both, the CPR tells you, yes, there is redistribution. And if you have a small baby and there is redistribution, there is higher risk. That has been very well demonstrated by many studies. So it's not don't use umbilical artery, it's use umbilical artery, but always integrated into the CPR. It's a very simple message, but you still will find hundreds and hundreds of cases that are managed only with umbilical artery, which shows how hard it is to remove a concept once it is integrated in our minds. And you're still finding a lot of fetal units or maternal fetal units in the world where they still only use umbilical artery. And there are still consensus experts where some experts vote that you should look at umbilical artery, despite having like more than 10 or 15 papers demonstrating clearly that this is not the case. I will talk a little bit more about what an expert is later. So, the CPR is the number one parameter, the number one parameter. But there have been other studies over recent years showing that aside from the cerebral-placental ratio, which classifies very well small fetuses into high risk and low risk, you should also use the uterine artery at the moment of diagnosis. Be aware that it's not screening uterine artery in the first trimester. I'm talking when you have picked up that this is a small fetus, you don't care about the uterine artery in the beginning. You look now at the uterine artery. If it's above the 95 centile, if you want to remember a very easy number is 1 in the third trimester, pulsatility index of 1 is above the 95 centile. It has an independent value. So it's either CPR, either uterine artery. Finally, the centile also has its weight. If the baby is not only small, but it is very small, it's below the third centile, this is an independent predictor of poorer outcome. So any of these three parameters independently predict. Sometimes you find the three in one fetus, but sometimes you just find one. My point is, if the baby that I was showing you had an abnormal uterine artery, this baby should be classified as fetal growth restriction. This is one study that we published about 3 years ago now, where we showed that this is 500 fetuses that were detected to be small. They all had normal umbilical artery by definition, as we said, and then these are controls that were undergoing induction of delivery. And this is the rate of adverse outcome that we defined as fetal distress for a cesarean section for fetal distress or neonatal acidosis. There was in controls, normally grown fetuses undergoing induction for other reasons, 8%. And then we classified the small fetuses into those with normal parameters, CPR, uterine artery, centile above 3, and the risk of adverse outcome was very similar. So when you take any of these abnormal, then the risk was 40%. So you see that by using the combination of these three parameters, and this is, of course, this is not fixed in time, I will discuss that. This is, we might be incorporating new parameters, but what I'm trying to illustrate is that if you combine different parameters in fetuses that they all had normal umbilical artery, you can stratify a population of low-risk cases that we call SGA today, and high-risk cases that we call fetal growth restriction. So the parameter that was missing there was uterine artery. I am insisting in the moment of diagnosis. And now I come to the other parameter I was mentioning. Should we measure growth, velocity? This is a study that, a very important and very well done study that was published also 2 years ago, sorry. The main goal of the study was to show that it's worthwhile doing an ultrasound in the third trimester. Okay, so that was the main goal of the study. But in addition to that, they assessed other things. And they looked at what is the weight where we could predict that is a poorer outcome in a small fetus. And they found that there was significance for some parameters, but they didn't find uterine artery Doppler. And because of this study, when you do consensus expert opinion, some of them say, no, uterine artery is not predictive. But in this study, in the SOVIO study, the uterine artery was considered to, when measured at 20 weeks. So it wasn't screening uterine artery, okay? What I'm talking is uterine artery measured at the moment of diagnosis. It's a very big difference, okay? The other parameter that was clearly associated was the growth velocity. But remember that those of you who have read this study and said, okay, the growth velocity could be useful, in this study, this analysis was retrospective. So they analyzed all cases, and they looked retrospectively, and they say, okay, those who did worse, the curve was lower, okay? And that's good, but this is a retrospective study. What is important is, when I use it prospectively, is growth velocity useful in classifying? There are two main problems with growth velocity. One is that you need to have measurements every 2 weeks, otherwise you cannot measure growth velocity. And the other one is that you need to have standards. What is a normal growth velocity in my population, okay? In many cases, we don't have these growth standards and we don't have these measurements. Several very recent studies have looked at growth velocity in their populations. This is a study that we published this year, and we really didn't find that there was an association with growth velocity. And we are not the only ones. There are other studies. So you see this was, again, we took like 300 small fetuses and then a very large population of 3,000 fetuses, and we said, which are the parameters that could help us to know if this small fetus was going to do well or was going to be in the higher risk group. The fetal growth centile didn't work in this parameter, but the uterine artery worked very well, the CPR worked very well, and the velocity was the worst. And there are 2 or 3 studies similar to that. So if you tell me, is it growth velocity useful? I tell you, I don't think we have complete evidence to say yes or no, but the main problem is that probably you don't have growth curves in your population, and the second is that in the majority of your small fetuses, you will not have these 3 or 4 measurements. If you have them and you see that the curve is going very down, okay, you could use it, but in the majority of cases, it's not applicable. However, in the majority of cases, you can do a cerebral-placental ratio, you can do uterine artery, okay? So I think as of today, and as I insist, this can change in future years, as of today, if you want to know if a small fetus is fetal growth restriction, which means is high risk, you should combine these 3 parameters, any of CPR, uterine artery, and the centile. And when doing that, you will change. You remember I show you this graph. You take your whole population, you only measure your umbilical artery, and only a small fraction of this fetus is classified as high risk here in the dark lines. But when you combine the 3 parameters that I just mentioned, you change completely. It's exactly the same population, and you go from 15% of your population being high risk to 65%, 2/3. So the main message is classify. And the second step, first identify, second classify into fetal growth restriction, high risk, or SGA, low risk, and do that by the combination of these 3 parameters. And as I said, why is it relevant? It's not relevant from a pathophysiological point of view. It is relevant because if it's fetal growth restriction, once we reach 37 weeks, we should go for active management. This means elective delivery. And if it's SGA, you can leave these fetus up to 40 or sometimes even 41 weeks. The evidence that we have for that is not very strong. In reality, it's a consensus. You don't have strong evidence to prove the point I'm mentioning. We have several randomized trials going on. This was the digital study where they compared induction versus expectant. But there was a cohort of small fetuses. They did not classify them into high and low risk. They found that they couldn't find differences, actually, but they said, okay, but we didn't classify them. So the authors were surprised by not finding difference. So in the final sentence of the paper, they say, despite we didn't find difference, we still believe it would be more rational to choose induction for small fetuses if you don't know whether it's high risk or low risk. And if you know, that's what it has to be defined in further studies. Because we have indirect evidence. These are two studies. I'm sorry, it's not very clear. This is a study that was published by Lindquist in 2005 with a very large cohort, and this is the mortality and morbidity of small fetuses according to the more severe cases when they are not detected, this line, and when they are detected. Okay, so when you detect small fetuses, the mortality is much less. So detection makes sense and so once you detect small fetuses just because they have been detected, we have good evidence that the outcome is going to be much better because you are aware, the patient is aware, she's going to be very much alert to fetal movements, you're going to perform more tests. So it's just by detection, the mortality goes down completely. And then by classifying into high risk and low risk, you avoid interventions because it's as bad to leave a small high-risk fetus in utero until 40 weeks because it could die before your eyes, but it's also bad when it's a small, low risk just for gestational age to do an induction because then you induce a lot of morbidity. We are starting having some studies supporting that. This is a study that has been published in the Ultrasound of Obstetrics and Gynecology. It's accepted for publication, so you can find it in the internet in PDF form. And I'm sorry because it's very blurred here, but I picked up this table. What they did in the study is they took the protocol that I have just mentioned to classify. They detected small fetuses, they classified them into high risk, low risk, according to our criteria, and they looked, is there any difference? And they compared that with a historical control. When they did that, they showed that when you classify fetus in the way that I have shown you, then you have more deliveries later, more vaginal deliveries, less inductions, less cesarean sections. So you improve, overall, you improve your outcomes. This is the first, it's a small study with not many hundreds of cases in each group, but it's very interesting because for the first time, it shows that the classification that I showed you works. And so that's exactly the point I wanted to make. Once you have identified small fetus, try to distinguish between SGA and fetal growth. And as I said, and this definition, high risk, low risk, is relevant. Of course, not all fetuses will be detected near term. The majority will, but not all. And in some other cases, then the third question becomes very relevant because you say, okay, this is a small fetus. I have classified in fetal growth restriction. I am 36 weeks. When I am 37, I will deliver, and that's it. Or I don't find any high risk. I will follow this case, and then I will wait until 40 weeks if nothing changes. But sometimes you have this early severe IUGR where the situation is more complicated because there you know that this baby could die or could have severe sequelae, and your main question is how should we follow up on timing the delivery of these more severe cases that are not so common, but of course we all see them. And that for this reason I thought I could use another case. This is a 32 weeks gestation, so it's not a horrible case, okay? But it's in the second centile. It has absent end-diastolic velocity in the umbilical artery, absent end-diastolic velocity, so everybody looks at that and gets very hysterical, and the patient as well, of course, because she sees the faces of the doctors. And the anatomy scan is normal, and there is a slight reduction in the amniotic fluid, which is below 5. Some of these parameters might be important or might be not. I'm just mentioning that to you because that's, again, it's a very typical description. And I was very recently consulted on a case, and they gave me exactly this information. That's why I picked up this case to put here. What did I say to the doctors? I said, well, my first recommendation would be look at the protocol, okay? Because that's the main problem. They look at that and they say, That's what we found. What should we do? And don't look at that. Try to put a label on that. Try to stratify it. Because reality is extremely complex. So if you're trying to understand life because you have become a Buddhist monk, it's good. Look at reality and don't try to use concepts because you will get very confused. But if you're doing medicine and you're having a patient in front of you, you have to get down to earth, unfortunately, for your happiness. And you have to use concepts because you have to simplify. Because you can start playing with these numbers. You could have an amniotic fluid of 6, you could have more, less, 3rd centile, 8th centile, and you get mad. You need to stratify to make decisions because you have 32 weeks and you have to say something, and the decisions are very easy. You should deliver, you should follow up. If you follow up, when should you follow up? Is it tomorrow? Is it in 2 weeks? When should I see this patient again? And if you don't simplify, you will never end. But then, so again, take your protocol, which I will briefly discuss at the end, and see, do you have all the information? And that's my main issue, is do you have all the information that you need to make a decision? It's absent in diastolic velocity. Is that a mild sign, or is it a very severe thing? The blood is stopping at the end of the diastole when it's going through the umbilical artery. The blood stops. There is no artery in your body where your blood stops at the end of the diastole. You're very sick when this happens. This means that your heart is starting failing, and there is huge placental resistance. So that's very severe. But what's your main concern? You're an obstetrician. You're very simple-minded, according to the rest of specialties. And your main concern is that this baby dies or not, right? Is this baby going to die? And everybody's going to me and say, how could you be so stupid to leave a fetus with absent and diastolic velocity in the uterus? Or is it not going to die? And then if I deliver, they will say, how could you be so stupid to deliver a baby at 32 weeks that was not going to die? Or if I say, okay, no, you're not going to die, come in 2 weeks, how could you be so mentally impaired to say a very severe case to come in 2 weeks? So what should you do? And you don't have to decide. You have protocols for that. That's a good thing. But is there any missing information here? Yeah, there is missing information. No? But is the uterine artery? Well, it could be, yes. But you already know that this case is severe, right? It has very severe signs. Karyotype infections, I will go straight to the point. There is good evidence that karyotype infections, unless it is very early, unless it is a very early case and it's atypical, they are not providing you information. So we normally would do a karyotype infections at 27 weeks, but at 32 weeks, that's such a typical case, and if the anatomy scan is normal and everything was normal normally, we would not recommend it. I will not go into details into that. You have protocols for that, and you can look at our protocol, which is published. Growth velocity, we said it was very difficult to have it at 37 weeks. At 32 it could be even more difficult, but okay, you could use it. But is this going to help you to decide what you have to do? You have to answer this question here in the left, lower left. Is this going to help? And this is, the picture is not very nice. You recognize this vessel? It's the ductus. Should we look at the ductus or not? Yes. We should. Why? Because we can make a big mistake, right? What is the chances, how are the chances of this baby every day that stays in utero if it's not going to die? Is it going to improve or doesn't matter? Every day in the utero is good for this baby? It's not or no? The doctors will tell you. I mean, is this baby going to die or not? If the baby is not going to die, what all literature says is that the longer you can keep the baby in, the better, because the mortality in these cases is much higher. Let me show you something, and I'm sorry because I have to change my presentation, but I'm sorry because my sight is really poor. I have to change glasses all the time. This is, we haven't published this data yet, but it's taking a long time. This is, but there are other studies showing that. And if you are interested, you can write to me, and I will reply to you in 2 months or 3, but I mean, I will send you the reference. The neonatal mortality, we classically say neonatal mortality goes down very much, and by 28 weeks, if you are in a very developed neonatal unit, you should be below 10% at 28, 30 weeks. And that is true unless you have a growth restriction fetus. The neonatal mortality goes, it's much higher. In some cases, it's double. So you see 26, 27. The main difference is at 26 to 28. So it tends to not be that high at 32 weeks. So 32 weeks could be a moment. But in general, as long as you are below 32 weeks, if you don't have a very good reason to deliver, you should look very carefully. And let's come back to this case where we were. So we are, let's say, somewhere halfway through. But in general, you should have a good reason to deliver a baby below 32 or 34 weeks. And so we need to come to consensus here. Should we look at the ductus venosus to make the decision, or we can make a decision already? It's a difficult question, because I put it on purpose because there are protocols who say yes and protocols that say no. Okay. In general, and again, what I wanted to illustrate with that. So some protocols tell you, and so let me go to explain what I want to say, and then I will come back to this case. So we discussed first this typical case of late growth restriction that appears later in pregnancy. The main problem you have in these cases is to know whether it's high risk or low risk, because you are going to deliver at 37 weeks, okay, or not. But as we said, there are these cases here. These are the severe ones, okay? And here the questions, as we said, is should we deliver, should we wait, how long should we wait? And then we know that we have many parameters, most of which are Dopplers, okay? Umbilical artery, middle cerebral artery, ductus. How should we combine these? And growth restriction, when it's early and severe, goes through a sequence of fetal deterioration. Okay? So it goes from placental disease, hypoxia, that is relatively compensated, acidosis, serious injury, and it has increment placental resistance, redistribution of flow to the brain. In the end, you have cardiac ischemia, the diastole is impaired, the heart becomes stiffer, and you want to know how far you are in this progression that will lead you to death, because you need to make a decision. There is a fire in the building, I'm going down the 40 steps of pregnancy, and I need to know when I have to jump, because the fire is really going to kill me. And of course, I want to go as close as possible to floor 0, but in some cases, I know that the fire could kill me and I have to jump, so I have to deliver the baby because it's going to die. And that's the main rationale of the follow-up of fetal growth restriction. How serious is the risk of this baby dying in utero? How serious is the risk if I take it out? If I take it out, if I deliver when the baby was not going to die at 29, 30 weeks, I might be making a big mistake. And we have good studies showing this concept. And so we need to understand that. And we use, let's say first, we use some, as we say, diagnostic markers, the ones that I was mentioning to you, cerebral placental ratio and uterine artery, to know whether it's fetal growth restriction and SGA. In late onset disease, that's the only information I need to know. But if it's an early onset disease, I need to know what is the risk of death, because essentially that's what I'm interested. The only thing I am interested is whether this baby is going to die or suffer a serious injury if I don't deliver this baby. That's the main question. We are 32 weeks, we are 30 weeks, and that's the main decision we want to make. And I think we have a huge body of evidence showing that Doppler assessment of the umbilical artery and the ductus venosus, this combination can show you the progression of these changes. And we don't have randomized studies, but we have quite good observational studies. So the baby will deteriorate, will go to absent end diastolic velocity, will go to reverse end diastolic velocity, and at the moment that reverse end diastolic velocity appears, the ductus venosus will become pulsatile, so it will be above P95, and then in the end it will be absent or reverse in the atrial flow. And at this moment, then we have very high risk of death. At this moment, if you are using computerized CTG, it will tell you that the baby is abnormal as well. And then very lately, the biophysical profile will become abnormal. So that's the main reason why Doppler is so good. Because if you are asking every day, when you start here at 29 weeks, the problem, and the baby has elevated pulsatility in the umbilical artery and vasodilation, but all the rest is normal, and you say, is this baby good or bad? Because I want to decide whether I want to deliver, yes or no. And you are using biophysical profile will be normal every day. And you will say, okay, today is good, how it will be tomorrow? And the biophysical profile will say, I don't know, ask me tomorrow. And then the third day you will say, biophysical profile, is the baby well or bad? And I'm, let's say, here, more or less, I don't know if you can see the, yeah. The biophysical profile will say, it's okay today, but how it will be tomorrow, I don't know. And in the end, we'll say, I don't know this question, how it will be tomorrow. Ask the Doppler knows. Doppler, the good thing of Doppler is that it's telling you how it is today, but more or less, of course, not perfectly, but it's telling you where you are in your pathway to fetal deterioration. It's, in a way, predicting in which stage of this deterioration you are. And that's why we have proposed to use stages. So you look at the, and I will go a little bit more in detail. I have 5 minutes to finish. So once you know that there's a severe growth restriction, early in pregnancy, you want to know the answer to the question I mentioned before. You know that if it's absent in diastolic velocity, more or less you have 3 weeks of latency. Latency means severe deterioration or fetal death. So you still have some time. We call that stage 2. And you could deliver at 32 or 34 weeks. There is more tendency to wait until 34 weeks because there are many studies showing that if the other parameters are normal, it is safe. If the only finding is absent in diastolic velocity and the rest, but you have to look at everything. If you cannot look at the ductus venosus, deliver at 32. But if you can look at the ductus and if the ductus is normal, normally you should still have 3 weeks ahead of you. So just wait, and you should follow this baby every 2-3 days. If it's stage 3, and I'm not going to stop in detail with that. I will show you where you can find it in the internet. It's very easy. There is a moment where you have reverse end diastolic flow in the umbilical artery. It is clearly worse than that. So as long as you don't have reverse end diastolic velocity, or the ductus is above the 95 centile, normally you should be able to wait until 34 weeks. If you have any of these signs, we call it stage 3 because the risk of death is substantially higher. And there is good agreement that it is not reasonable to wait longer. That you will find some protocols that mention 30 weeks, some of them mention 28. Our opinion is 30 weeks. This is arbitrary convention. So, and you should follow every day. So that's a very severe case. It could really die, but if you are less than 30 weeks, it is still safer to keep this baby in than to deliver it if you are less than 30 weeks. Why? Because the consequences of prematurity are still worse, right? And then at a given moment, this baby goes into the cascade of final deterioration. So the ductus will have absent or reverse flow during the atrial phase. If you are using computerized CTG, the computerized CTG will start telling you, okay, we are in a very high-risk situation, so both tests are good for that. And this tells you normally on average that you have 4-7 days before this baby dies. And then in the end, indeed, the biophysical profile will become abnormal, but that's very, very late, as I said. And finally, of course, if you decided to do an experiment of nature and you look at this baby, you will start observing the celebrations that precede fetal death. So we all call it stage 4, but really what you should be using is the doctors or the computerized CTG. And in these cases, indeed, you should really deliver at any time. So more or less what you should do when you see a case, as I was showing you, 32 weeks, is see, okay, which stage I am. And then I am following this protocol, or we are in a big hospital and we have adapted a protocol to our reality. So use the protocol, that's the main message. Don't try to look at the particular details because you will get very confused. Try to go down to a stage. You could call it stage 2, B, whatever classification you want to use, right? That's the main summary, again. And that's also the summary of what I was saying. So if there is a late, mild, small fetus, they all will be in stage 1, right? So the main decision is it high risk or low risk? Is it fetal growth restriction? Is it small for gestational age? But if you are less than 34 weeks, 32 weeks, then you really need to use stage C. Okay, we are in stage 1. You might be in stage 1 in a fetus at 32 weeks. We're in stage 2, stage 4, and then make the decisions according to that. One of the big things we have taken from the literature is that when you are using a protocol, the mortality goes down amazingly. You find observational series in the literature saying that when you have early severe growth restriction fetuses, the mortality was very high, exceedingly 15, 20%. But when they did the truffle study, a very important study which demonstrated that the ductus venosus is the most useful parameter to follow up very severe cases, just by using a protocol, they reduced mortality to 3%. And when they have done studies at the end of gestation, the digital study that I mentioned earlier, they didn't have any stillbirth in 400 cases of small fetuses just by detecting and following up babies. So it's not so important when exactly you deliver. Is it 32, is it 34? The most important thing is to use a protocol and a structured protocol. Okay? That's the final summary of all what I said. So the first step is to identify the smallness, to be sure that it's isolated. Sorry, the type of the letter is not very big. The second is to distinguish between low risk and fetal growth restriction or high risk. And for that, you need to use a combination of parameters, CPR, uterine artery, estimated fetal weight. You classify them, and then it could be a low risk. In this case, you can wait until 40 weeks and follow every 2 weeks. I could not go into detail in all the evidences, but there is good evidence that is useless to follow a low-risk case at intervals that are less than 1 week. That less than 2 weeks, sorry. It has to be 2 weeks, okay? And that is good evidence for that. If it's classified as high risk, if it's fetal growth restriction stage 1, then you should deliver at 37 weeks, follow every week, not every 2 weeks, every week, and then as the case goes to higher degrees. And as I say, you can change these numbers. In my setting, we will change that to 32 weeks. Okay, that's good. I mean, there is not super strong evidence. The most important concept is that you need to have a protocol because that has a main impact in your management of these cases. And we have to stop here. I hope I was clear. It's a very short time, but I hope I could make my points. Thank you very much.